And in the spine view that is on the left side of screen, we can see with the rise tube in situ, there are valvulae conventis that is gives a concertina effect. We can see multiple loops, whitish bands, which are characteristic of the small ball that is of the jejunum. The additional biological therapies that are available, one is that target integrins, that is natalizumab and bidolizumab, or that target interleukins, interleukin 12 and 23 is ustekinumab. We have to remember some of these terms, and these can be the basis of question in our super specialty examination. Welcome to our channel, viewers. This is second video tutorial on inflammatory bowel disease. In this video tutorial, we have talked about Crohn's disease. In the previous video, we have discussed in detail about the ulcerative colitis. Crohn's disease is a puzzling subject, and I find medical student and surgical trainees struggling with this topic to understand. We have covered in detail everything a beginner or trainee needs to know about the Crohn's disease, and we have combined theoretical discussion with a case-based discussion. I hope you will enjoy the talk. Stay tuned. This is a real life case scenario which I am giving to you. The diagnosis can be anything. It is not that it is Crohn disease only that we are discussing. So keep your option wide and let's start. So this is a 38-year-old male who has presented to us with history of abdominal pain for last 5 months, history of diarrhea for last 4 months, and intermittent history of non-passage of stool and flatus for last 4 months. So the main presentation is pain abdomen, diarrhea, and intermittent obstipation for last 4 to 5 months. The pain was acute in onset. It's located in the central abdomen, colicky in nature, and used to get aggravated by food. There was no history of any radiation or referral to any other site. He had a history of diarrhea, which was 5 to 7 episodes per day. It was semi-solid in consistency. There was history of loss of weight, which was undocumented loss of weight. And he also gave history of obstipation for last 2 days before presenting to the hospital, along with abdominal distension. He also gave a history of nocturnal symptom that he used to have the aggravation of symptom during night. There is no history of fever, any GI bleed, lump abdomen. Uh, there was a history of appendectomy at the age of 13 years. On abdominal examination, the bowel sounds were increased and there was mild distension present at the time of presentation. There were no visible peristalsis, lump, or tenderness. His rectal examination was normal and his general physical examination was also unremarkable. We manage this patient on the line of acute intestinal obstruction with the help of IV fluids and other conservative measures. Rice tube was inserted, and patient started showing improvement after 48 hours, and he started passing stool and flatus after 48 hours of conservative management. Friends, make your plan. What is the diagnosis? What could be the differential diagnosis in this patient? And what are the further investigation required to work up this case and manage this case in a 38-year-old male patient with history of recurrent intestinal obstruction of almost 5 to 6 months duration. So coming to the topic of this video tutorial, the ulcerative colitis and Crohn disease, there are two phenotype patterns of inflammatory bowel disease. In Crohn disease, the inflammation is transmural. That means it involves the whole bowel wall and it occurs in any part of GIT from mouth to anus, and it associated with development of complications such as fistula or stricture. While the ulcerative colitis, which we have talked in detail in the previous video tutorial, the link for which I have shared in the description, it is superficial inflammation that occurs only on the colon. So that we have to understand from the very beginning that Crohn disease affects whole GIT from mouth to anus, and it is a transmural. That means it involves the whole bowel wall from the mucosa up to serosa. While the ulcerative colitis, it affects only and only colon and maybe some part of the terminal ileum that we call backwash ileitis, and it affects only superficial part of the mucosa and submucosa, and there is no transmural inflammation. So, with this basic understanding, we'll start discussing the Crohn disease in this video. The Crohn disease is a lifelong disease, and it arises because the interaction between genetic and environmental factor. So that the person who is genetically predisposed comes to the susceptible environment, he will get the Crohn disease. The Crohn disease is predominantly found in the developed country, but the landscape is quickly changing. That means more and more cases we are seeing in the developing countries, and more and more patients are coming to us in the clinical practice. The precise etiology is not known, so therefore a causal therapy is not yet available. So that we don't know the cause, so we don't have any specific curative treatment. And it is unlikely that the precise pathogenesis of Crohn disease will be understood soon because we are not getting any breakthrough despite the extensive research about the etiology of Crohn disease. The most of the facts and figures which I have given in this talk are from these consensus guidelines, that is third European evidence-based consensus on diagnosis and management of Crohn disease part 1 and part 2, and ECCO ACG consensus on surgery for Crohn disease from journals of Crohn's and colitis, published in 2017 and 18. So let's understand about Crohn disease activity index, because its reference will come time and again while we discuss about this disease, and in different journal also there is a mention of Crohn disease activity index. It is basically a calculation depending on different variables, like number of liquid stool per day, abdominal pain, general well-being of the patients, number of complications like arthralgia, iritis, erythema nodosum, pyoderma gangrenosum, etc., fever, and need for opiates for the diarrhea, abdominal mass, deviation from normal hematocrit, or deviation from standard weight. The Crohn disease activity index, that CDI less than 150 indicate a remission, while more than 450 indicates severely ill, that is a very severe disease. There are many online calculators available for calculating the Crohn disease activity index, and MDKL is one of that type of online calculator where we can simply uh, input the values, and online we can calculate the Crohn disease activity index. So, for the purpose of trials, most clinical trials will recruit patients with Crohn disease activity more than 220. Remission, as I said, is widely accepted when the Crohn disease activity index is less than 150. And response in Crohn disease after treatment is defined as a decrease in Crohn disease activity index more than or equal to 100 points. Relapse for the purpose of clinical trial is when the Crohn disease activity index is more than 150 with an increase of more than 70 points from the baseline, and the lapses may be called infrequent if it is less than equal to 1 per year, and frequent if it is more than 2 or equal to 2 per year, or continuous if the patient has a persistent symptoms of active Crohn disease without a period of remission. The Crohn disease is called steroid refractory if patient is having active disease despite prednisolone up to 1 mg per kg per day for a period of 4 weeks. Patients who are either unable to reduce steroids below the equivalent of prednisolone 10 mg per day or budesonide below 3 mg per day within 3 months of starting steroids without recurrent active disease, or patient who have a relapse within 3 months of stopping steroids, they are called steroid dependent disease. The term recurrence in Crohn disease is best used to define the reappearance of lesion after surgical resection, and relapse refers to the reappearance of symptoms as above after the treatment. The another term in Crohn disease will be localized or extensive Crohn disease. It will be called as a localized Crohn disease if the intestinal Crohn disease is affecting less than 30 centimeter of the bowel length. This usually applies to the ileocecal location, that is less than 30 centimeter of ileum and the right colon is involved, but could apply to the isolated chronic disease or conceivably to proximally small intestinal disease. That means if less than 30 centimeter bowel length is involved, it will be called as a localized Crohn disease. Another term used is extensive Crohn disease when the length of bowel involved is more than 100 centimeter in whatever the location, and this applies to the sum of inflammation in discontinuous segments. That means if the part of the colon, part of the ileum, and part of the jejunum involved, and total length involved is more than 100 centimeter, it will be labeled as extensive Crohn disease. There is a gray area with no clarity in the description on any consensus guidelines, that is between 30 and 100 centimeter, and this length is arbitrary and we don't know where to place that patient in localized disease or extensive disease. The clinical features of Crohn's disease are chronic diarrhea, and it is the most common presenting symptom. That patient will present with long-standing diarrhea of months duration, that will be 4 to 6 months or longer. A decrease in fecal consistency of more than 6 weeks may be an adequate symptom to differentiate this from self-limited or infectious diarrhea. This I have talked in my previous video also in ulcerative colitis, that any diarrhea which is persisting beyond more than 6 weeks should not be considered as infective diarrhea, and we should think on the lines of inflammatory bowel disease. Acute terminal ileal Crohn's disease may be mistaken for acute appendicitis, and that becomes one of the differential diagnoses of acute appendicitis. That is the ileal involvement in Crohn's disease. Chronic non-specific symptoms in children mimicking irritable bowel syndrome, that is IBS, like unexplained anemia and growth failure, should also be considered to avoid delayed diagnosis in children. Other features of Crohn's disease are abdominal pain, which is seen in up to 80% of patients, unexplained weight loss in 60% of the patient, blood and mucus in the stool may be seen in up to 40 to 50% of patients with Crohn's colitis, but less frequent than in ulcerative colitis, in which the bloody diarrhea or mucus is seen up to 80 to 90% of cases. The perineal fistulas are present in 4 to 10% of the patient at the time of diagnosis and may be a presenting complaint. So, any patient with recurrent complex fistulas, we should keep in mind the differential diagnosis of Crohn's disease. In a suspected case of Crohn's disease, a full history should include the detailed questioning regarding the onset of symptom, recent travel history to rule out infectious diarrhea or amoebic colitis, food intolerance, and medications, the history of appendectomy and the age at the time of appendectomy. The particular attention should be given to the well-proven risk for Crohn's disease like smoking, family history of inflammatory bowel disease, and recent infectious gastroenteritis, which may flare up the inflammatory bowel disease. Careful questioning about the nocturnal symptoms. As I said before, also the nocturnal symptoms should not be there in case of irritable bowel syndrome, and if they are more in the night time, we should think on the line of inflammatory bowel disease and Crohn's disease. The feature of extra-intestinal manifestation involving the mouth, skin, eye, or joints, episode of perineal abscess or anal fissure should be inquired in detail in a suspected case of Crohn's disease. The nocturnal symptoms in Crohn's disease are flare-ups at the night, pain in abdomen, frequent visit to the bathroom, which all disturb the sleep at night, and that lack of sleep could also make Crohn's disease worse. The extra-intestinal manifestation in Crohn's disease, they are categorized in two groups. But one which is related to a disease activity, that means they are more severe. If the disease is more severe, that are erythema nodosum, seen in 5 to 10% cases, conjunctivitis 3 to 10%, acute arthropathy 6 to 12, and after ulceration in 10%. Other Extraintestinal manifestations which are not related to disease activity are sacroiliitis in 10 to 15% of cases, ankylosing spondylitis 1 to 2%, primary sclerosing cholangitis, which is rare and common in ulcerative colitis, gallstone in 15 to 30%, and renal calculi in 5 to 10% of cases. So, coming back to our case, that we have a 38-year-old male with the recurrent history of subacute intestinal obstruction and chronic diarrhea, pain, abdomen, unexplained weight loss with nocturnal symptoms, and diarrhea of long duration for 4 to 5 months. We have a clinical diagnosis of recurrent acute intestinal obstruction or subacute intestinal obstruction. The common differential diagnosis in a case of acute intestinal obstruction in decreasing order of frequency are adhesions, small intestine stricture, which can be caused of the TB, Crohn disease, or ischemic, hernias, internal and external, interception, tumors, which can be GIST or adenocarcinoma, and worms. So we have a diagnosis of recurrent acute intestinal obstruction with chronic diarrhea in young male with these differential. So we have to work up our case and plan our management ahead. On evaluation of this patient, his routine workup, including complete blood count, RFT, LFT, electrolytes were normal, biomarker was negative, and we asked for the X-ray abdomen, standing, and spine. So, for medical students and trainee, in any case of acute intestinal obstruction, X-ray abdomen, standing, and spine are the basic investigation that we have to get in every patient. And the X-ray abdomen erect is for airflow level, and spine is to characterize the bowel loop. The on the right side of the screen is X-ray abdomen standing, which is showing multiple airflow level in a step ladder pattern, which is characteristic of small bowel obstruction. The bowel loop is considered dilated if the ileal diameter is more than 2.5 centimeter or jejunal diameter is more than 3 centimeter. And in the spine view that is on the left side of screen, we can see with the rise tube in situ, there are bulbae conventis that is gives a concertina effect. We can see multiple loops, whitish bands, which are characteristic of the small bowel, that is of the jejunum. Another characteristic feature of small bowel obstruction is that in small bowel, the airflow level of the dilated bowel will occupy the central part of the abdomen. This X-ray abdomen, standing at spine is of a different patient, not related to the index case. For comparison, this is a case of large bowel obstruction where we can see that there are multiple airflow level which are towards the periphery, and step-ladder pattern is not there, and there are hostra which are more parallel and usually up to the one-third of the diameter of the bowel. We call we call it the bowel loop dilated if the cecum diameter is more than 8 centimeter or the colonic diameter is more than 5 centimeter. In the figure, in the X-ray on the left side, we can see large hostel loop of the transverse colon, and in the center part, as highlighted, is the small bowel loops because of the back pressure changes. So we can see the bulbae conventis and Hofstra health comparison. These X-rays are not related to the case we are discussing. I have given only for the purpose of teaching to the graduates and postgraduate students. So now we have a radiological evidence of acute intestinal small bowel obstruction, and patient has shown some signs of improvement in the form of settlement of distension and passage of stool apparatus. So for reaching the diagnosis of this patient, but further workup you want, please think about it, write it down, and we'll discuss as the discussion evolves. The endoscopy and radiology are complementary diagnostic modality while investigating a case of Crohn disease. The Crohn disease may affect proximal small bowel, that is proximal jejunum, in 10% of the patient, which is out of the reach of the endoscope. The CT and MRI are current standard for assessing the small intestine. Both technique can establish disease extension and activity based on ball thickness and increased intravenous contrast enhancement. The magnitude of these changes, along with presence of edema and ulceration, allows categorization of disease severity. The CT MRI enterography has similar accuracy in detection of active Crohn's disease in comparison with CT oblique MRI enteroclasses with NJ tube. So there are two terms, one is CT enterography, one is CT enteroclasses. So in CT enterography, we give negative contrast in the form of say PEG-leg, and in enteroclysis, along with the contrast, we give inject air with the help of endoscopically placed NG tube. It is a invasive procedure, so CT enterography is equally good and safer technique while assessing a case of Crohn's disease and small bowel involvement. For confirming the diagnosis, we recommend ileocolonoscopy, or the literature recommends ileocolonoscopy with multiple biopsy, and it's a well established as a first line procedure for diagnosing the Crohn's disease. The endoscopic hallmark for Crohn's disease are patchy distribution of inflammation with skip lesion. The Crohn's disease ulcer tend to be longitudinal and may be associated with the cobblestone appearance of the ileum or colon, fissures, orifices, and strictures. The rectal sparing is often encountered, while circumferential continuous inflammation is rare. The gastroduodenal involvement in Crohn's disease is reported in only 2 to 4% of cases. So these are all the basis of question for super specialty examination like NEET super specialty or MCH examination, and these are all contrast feature as compared to the ulcerative colitis. In ulcerative colitis, the rectum is always involved. The inflammation is continuous, confluent, and concentric. There is 3C for UC. While in Crohn's disease, it is patchy, linear, and skip lesion with cobblestoning, and there can be a rectal sparing. Fissuras are uncommon in ulcerative colitis and common in Crohn's disease. The gastroduodenal involvement in Crohn's disease is reported in 2 to 4% of cases, but never seen in ulcerative colitis. Thanks for watching, viewers. We hope we could add some new insight to your knowledge, and you'll be able to manage Crohn's disease patient more efficiently. Thanks for watching. Please like, subscribe, and share. The channel subscription is free for life, and knowledge is invaluable. Thanks again. Happy learning.